And happy Friday. So, only a couple more weeks left. Are you guys ready? The last couple weeks are going to be a little bit rough, right? Got a lot going on. All right. So for us, just moving forward for the rest of the term, where'd it just go? I just had it up. Where'd it go? Um, Let me pull it back up. I just had the syllabus up. I must have accidentally closed it down. So, so for tonight, Samira, is your camera? Can you turn your camera on? Thank you. All right. So for week 8, we have today we're going to talk about nursing theory, and we are going to talk about critical thinking. Um, and so don't forget your NCSBN decision paper. Um, is due this week as well. Sorry. And then, oops, we have our exam 3 is not until, well, so we have quiz 5, which will be next week. And then we'll have exam 3 in week 10. And then, of course, week 11 is going to be your HESI, and then week 12. So, I mean, we're right here at the end. Um, so for week 12, I'm done. Going to double check, but there may be an alternate meeting day, meaning that we won't meet on Friday. We may meet earlier in the week. Um, So I'm not 100% sure, but I can check real quick. I don't know if it's posted yet. The other question I have for everybody, which is going to require somebody to say, um, so with exam 3 coming up, what is a good day for exam 3 review? Does anybody I know I've been doing them on Friday mornings. I don't know if that continues to be a good day or if we need to try for a different day. Friday morning is still good. Okay. So that is fine. We will do it Friday morning. Then I will do it. We'll just say 10 o'clock on Friday morning. I'll post it in the announcements. And no, nothing has been posted for the last week yet. Okay. So I will post it in the announcement. We'll do the exam review Friday morning at 10. If between now and exam 3, if anybody wants to meet for tutoring, please send me an email with some days and times that you guys are available if you want to meet, and we can get something set up. Um, so again, next week we'll have quiz 5. Then we will have exam 3 in week 10. Week 11 is your HESI. And then, of course, week 12 is the last day of class. So today and next week really are going to be like cap walks is on. After exam 3. We usually have class after the exams. That's not going to change, but except after exam 3, we are going to do our HESI review. So there won't be a separate HESI review. We're going to do it after the exam. Um, I also will post prior HESI reviews so that you guys can, have, multiple reviews to look at while you guys are preparing for HESI. So like I said, today we're going to talk about nursing theory and critical thinking. If we have any additional time after, we'll do some practice questions. Um, so let me stop. Any questions for me?
No.
Because I can just, me, I can talk. So, all right. So let me share my screen. So just so you know, If you don't have it, chapter 13 um in your concept or your success book is going to be your nursing theory chapter. And then the critical thinking chapter is chapter 5. All right. So here we go. I love nursing theory, guys. Nursing theory is awesome. Um, Not everybody feels the same way, but there's lots of good things about nursing theory and lots of foundational things. So, oops. When we look at nursing theory, nursing theory is important. And so there's lots of theories. There's lots of nursing theories out there, okay? We're only going to talk about a few of them here. And so some of the nursing theories that are out there obviously are going to be strictly prior, just talking about like patient care, building relationships, those therapeutic relationships and things like that. And then there are some theories too, nursing theories that we use when we develop nursing curriculum. All right. So when we're building courses or not building courses, but when we're building curriculum, we will use nursing theory as a foundation. And, even though, probably not having, an extensive review of nursing theories are the foundation for a lot of the things that we do as nurses. So whether you've actually heard the theory, like specifically, as we talk about some of these, you'll kind of see how they correlate with how we perform or how we speak to our patients, but how we provide that patient care. There's three concepts that are important to nursing, right? Obviously, the person or the patient, right? The person that we're caring for, the recipient of the care, the health, which is, or not the health, but health, which is our goal of nursing, right? Goal is to try to restore them back to their previous level of functioning or as close to their previous level of functioning. And then the environment. So where does the nursing care take place? So the first one we have is Florence Nightingale. And I hope everybody has heard of Florence before. If not, I need everybody to go back and see who Florence was. But Florence Nightingale, she was considered the first nursing theorist. If you know anything about Florence, if you remember, I think we talked about her somewhere in the beginning of the course. During, the Crimean War, when she volunteered to go help those soldiers, can't even say the word. She was the first to emphasize the environment, right? Ventilation, warmth, noise, light, cleanliness, all those really important things that we know help to contribute to positive patient care. So she felt strongly that environmental issues influenced the course of treatment. And she was initially a statistician. So she went over there and she looked at, how many of those soldiers were dying unnecessarily in a lot of cases. And she did collected a lot of data, did her own research. And so hence, we have things like, washing our hands, right? Making sure that the environment is clean, that they have fresh air. So again, I'm
I'm
sorry,
sorry.
Ashley, did
So
you
did
want?
you? Oh, I hit unmute by accident.
Oh, okay. Mhm. Then we have Abraham Maslow. And so Abraham Maslow is not a nurse. He was actually a psychologist. And I'm sure pretty much all of you have heard about Abraham Maslow before. He developed his human needs theory, right? So we use this a lot in nursing when we're prioritizing our patients' care. And so the general description of his theory states that certain internal, external, physical and psychological needs are common to all people, right? We all need to breathe. We all need food, right? We all need water. We all need shelter, right? That's just the tip of the iceberg, but right, those are some basic needs that are common to all people. And he arranged those in a hierarchy, right? So most of the time when we see Maslow's hierarchy, we notice it's in a triangle, right? And so all those basic needs are at the bottom of the triangle, and a person, as they go through, try to get to that highest level, which is self-actualization. So we look at what unmet needs are. So unmet needs create tension, which motivates the person to react to meet that need, right? What happens if we don't have food or water, right? We get hangry, right? That's a motivation for us to go get some food, to get some water, right? So we can, fulfill that need. What happens when we need to use the restroom, right? Can't, hold on to it forever, right? That's a motivator. So, an unmet need creates tension, which motivates the person to react to meet that need. And once those needs are met, right, we're not aware of it anymore, right? Once you eat some food and you got food in your belly, you're not hangry anymore, right? And you don't think about being hungry because you're not hungry anymore. You met that need. Um, the dominant needs that matter to a person can vary in life as well, right? So some of the things that you considered more important when you were younger maybe aren't as important to you as you get older, maybe except for those basic needs, and vice versa, right? Some things that weren't important to you as you were young when you were younger might be important to you as you get older. But again, his needs, that's nice little hierarchy, and we're always striving, right, to get to the next level. The next one we have is Dorothea Orem and her self-care deficit theory. Okay, so Dorothea's theory, it's a general theory, it has three sub-theories underneath it: self-care, self-care deficit, and our nursing system. So when we look at self-care, this is a goal that is directed toward a safer environment for life, health, and well-being. Okay, so ideally here in the self-care part, individuals learn to respond to health cues in themselves, or the environment as a way to maintain personal health. With the self-care deficit, for whatever reason, the personal care is not meeting the therapeutic self-care demands. Okay, so maybe they don't recognize or know what to do in regards to a health situation, right? Um, I all of a sudden have pain in my, in my side or in my abdomen, or I have an injury, or I had the onset of an illness, right? And what happens, right? We have to seek healthcare. Anybody that comes into the healthcare system, regardless of the area, whether it's in a hospital, a clinic, doctor's office, generally have some sort of a healthcare deficit, right? Because they are unable to know what to do. And then the nursing system, right? So think about everything that we are going to do as nurses, right? We empower clients through our relationship to help meet their self-care demands. So we are treating these patients holistically, right, in order to care for them. Madeline Leninger, okay, hers was a cultural care theory, and we've talked about cultural care, we've talked about religious and spiritual as well. And so she had a huge interest in cultural care and how nursing responds to people of different cultures. So she recognized that there was a link to understanding care based on a person's cultural background, right? Hence, we have our cultural care theory, and we also, right, incorporate cultural care into our education and our practice. So she identified that there were two kinds of care in every culture. Okay. So one is generic. Generic is the home remedies that are used in care. Okay. Some of these are culturally based. Some of them may not be cultural based, right? What happens when you have a headache, right? Take some Tylenol, you take some ibuprofen, right? That may not mean, that may not be cultural, right? That's just what, we've been taught to do. And then we have the professional care. And professional care is care that's provided by people who are specifically trained to provide care. So your doctors, your nurses, right? Other members of the healthcare team. Savannah, are you there? I don't see her. Okay. And then we have her three modes that guide decisions when providing care. All right. And so with those, we have cultural care preservation or maintenance, cultural care accommodation or negotiation, and then cultural care patterning, or restructuring. So cultural care preservation or maintenance, okay, this means that we're incorporating, right, those cultural care into that patient's plan of care. Okay. And so as long, again, if you remember with some of the basic foundations of cultural care, as long as it is not harmful, right, or doesn't infringe on the rights of other people, right, then we can incorporate their cultural care into their plan of care. Now, cultural care accommodations or negotiation and cultural care repatterning or restructuring, these can sound very similar. Okay, and so I'm going to pull up the book real quick and I'm going to use the examples in the book to kind of guide how these are. So when we look at, give me one, okay, cultural care accommodation or negotiation. Okay, so an example of this. Some cultures, Vicks Vapor Rub is placed in the nostrils, which can potentially be aspirated and lead to pneumonia. Okay. I love Vicks Vapor Rub. I love the smell. Like it does make you feel good, especially when you're really congested. Okay. But again, putting it in the nostrils is not the best idea, right? Again, it can be aspirated, which can lead to pneumonia. So an accommodation or negotiation, okay, would be to demonstrate a more effective way to use Vicks, okay, would be rubbing it on the chest and neck, right, rather than placing it on the nose. Um, and I will tell you, has anybody put they I've never put it in my nostrils. Have you ever put it under your nose though? Has
Yeah, it
anybody here?
opens it up.
It does open it up, but it can
Mhm.
burn your skin. First, your facial skin is much more sensitive than your chest. I was so sick. This was a couple months ago. Um, and I couldn't breathe. So I was like, well, I'm going to put a little bit of Vicks under my nose and it
Mhm.
burned, not going to lie. And then I would sleep with the fan on. And so when I laid down, and not only was it burning, but when the fan hit it, it made it burn even more. It was horrible. Um, But regardless, that is what the example of a combination is. You can still use your VIX. We're just going to teach you a safer way to use it. When we look at cultural care repatterning or restructuring, again, I'm going to use the book example. Leninger's theory is concerned with respecting cultural differences, yet providing a safe and protective environment. So in some cultures, mud is placed on the infant's umbilicus after delivery. I had not known that. Because of concern for local and systemic infection, the visiting nurse provided clean pads. The nurse demonstrated their use, how to clean the area, and then how to leave the area uncovered for a period so the umbilicus could be exposed to air. Okay, so the patterning or the restructuring, right, is trying to avoid some of those um, cultural preferences that could potentially be dangerous. Okay, so we don't want to put mud on the umbilicus, right, because of the risk for infection. So we, repatterned it and tried something different. Okay, so accommodations, a more effective, proper way to use something. And then with repatterning, we're trying to um, prevent them from using a, I don't even know how to say, preventing them from using something that could potentially be harmful rather than helpful. And then we have Hildegard Peplau. So Hildegard Peplau, she has her interpersonal, sorry, relations theory, and this is a basis for developing that therapeutic relationship with our clients. Okay, and so there are three overlapping phases of Peplau's theory. So the first one is orientation. Okay, so the client seeks assistance because of a felt need. Are they ill? Do they have an injury, trauma? Okay. And then that nurse works with the client and helps them recognize the problem. Okay. And that's the beginning of that therapeutic relationship. With identification, now the client understands the situation and is going to respond to the nurse that is providing the care. And then during the exploitation phase, the client starts to begins to depend on the nurse, okay, and will use the help offer. And then the resolution, this is where the relationship ends, okay? So they're no longer dependent on the nurse for care, okay? And, they can now care for themselves, whether it's being discharged, transferred, whatever it is. Rosenstock, Rosenstock's health belief theory, oh my gosh, theory, tries to explain why or why not a person will take action to prevent or detect illness. Okay. So why or why not somebody would not take actions to prevent or detect illness. And so according to his theory, perceptions vary. They may have no basis in reality. Beliefs are connected to existing barriers, or a cue to action is seen as necessary. So perceptions vary and have no basis in reality. And so there's a variety of things. Maybe they don't feel they need to seek healthcare for whatever it is. It could be that it is embarrassing for them and they don't want to seek healthcare. And a lot of times, right, that's why people, for a variety of reasons, don't seek healthcare. And then we start, we do get them in the healthcare system and diseases and other things are found at much later stages. Beliefs are connected to existing barriers. It can be expensive. It could be, inconvenient, or even sometimes painful, right? Just it really depends on the situation. If your doctor's office is only open from 9 to 5, and those are your working hours, you're like, well, I can't get to the doctor for my annual checkup because they're only open at the same times that, I have to be at work. Um, Expensive. Again, not everybody has health insurance, and so costs of healthcare can be expensive. And it also, they may worry about it being painful, right? If I have to have a biopsy or a surgery, right? We know that there's going to be some pain involved in those. And then that cue to action. So, more so even now, I don't know how many people watch TV. There's even commercials on the radio, on the radio as well. If I'm in pain, obviously I'm going to go to the doctor because I'm like, especially if your pain is uncontrolled and nothing is working. Sometimes a news story or even a commercial on TV. And like I was saying, even more so now, we see a lot more or hear a lot more about diseases, right? Some of those chronic diseases. I think, like liver disease is very, I've been seeing a lot of those or hearing a lot of those, hypertension, even diabetes and other things, right? So what, or, if you hear a news story about a related diagnosis, right? These may prompt somebody. And the goal is to reach as many people as possible. And that's why they use TV and radio for these things. Um, and they may say, oh, wait, that might relate to me. Maybe I should make a doctor's appointment, right? And go get checked out. Or even a reminder call from your doctor's office, right? Hey, Mrs. Smith, it's time for your annual checkup or your mammogram, or Mr. Smith, it's time for your prostate exam, whatever it is, right? Sometimes that little reminder may be like, okay, well, maybe I really should go get checked out. Um, we have Sister Calista Roy. So Sister Roy describes the recipient of care or the client as a holistic adaptive system, right? That's that holistic care that we've been teaching you about. In her, and this is her adaptation model. Okay, so with this, we have both internal and external stimuli that affect the system. Okay, and she describes the types of stimuli as either focal, contextual, or residual. Okay, so focal is something direct, right? Such as a client experiencing pain. The contextual meaning other factors that affect the focal stimuli. Okay, so let's say you go in because you rolled your ankle. All right, walking down the stairs and you rolled your ankle, and now you're in pain. You go to the doctor, you go to the urgent care. What are they going to do? Because healthcare providers, like, we like to touch things, right? We want to manipulate. So you're in there because you rolled your ankle and your ankle hurts. And now what's happening? The doctor is, going in and he's touching the ankle, and that, could increase the pain. The residual is internal and external factors that may not always be evident. Okay. Meaning, maybe you had, a previous experience where maybe you hurt that same ankle, or you hurt another part of your body, okay, and you have the memory of that, that prior pain that can also affect you. So that's the residual. Our coping mechanisms, okay, these are regulator and cognator subsystems, right? So regulator subsystems, those are the internal effects that take place in response to what is happening internally. All right. So the body tries to regulate the system when it is being negatively affected, right? We have the whole purpose is, to maintain homeostasis in our body. Um, and then we have the cognator subsystem, and that's the learning, the processing, the judging, and emotion that the client uses to cope with what has happened, right? Could be something as small as rolling your ankle, spraining your ankle, or maybe worse, maybe when you rolled your ankle, you actually fractured your ankle, right? So it is how we, deal with that situation. And then we have Jean Watson. And Jean Watson, this is a really big one in healthcare, her theory of human care. And so she said that, or yeah, she said that health is harmony among the body, the mind, and the spirit. It also involves self-perception and how the self is experienced. And illness is a lack of harmony within the self and the soul, right? When we're sick, right? There's some disharmony that goes on. So the nurse's role is a caring process to help the client regain harmony and health. And so through the caring process, which that's the theory of human care, um, the client develops self-knowledge, also develops self-healing, and then that allows the client to solve problems and to grow, and even the nurse can grow. So we can grow through our experiences of caring for other people, right? And how caring for them, and you can use prior experiences, right? Moving with other clients. So those were the theories that we are going to cover. Raise your hand if you're going to go back to get your RN, your BSN, all of those wonderful things. All right. So when you get into maybe depends on the RN program, but definitely in your BSN program and moving on up, you will get a lot more about nursing theory. um, nursingtheory.org is a really good website. Not saying you have to go there. I'm just saying it's a good reference site. You can kind of see all the different nursing theories that are out there, how they were developed, why they were developed, and what they are. Sometimes even the application to, how we use these theories in nursing, which is going to bring us to this. So, in order for nurses or anybody, right, to establish a theory, they have to do research. Okay. And research in any profession supports existing knowledge, develops new knowledge as well. So you can go all the way back to Florence with this, right? And we talked about Nightingale. I said she was a statistician. She volunteered to go help the soldiers during the wounded soldiers during the Crimean War. Okay. And she took those numbers. She looked at the morbidity and the mortality, and she was like, what in the heck, right? And that's when she started, okay, what can we do better, right, to improve the outcomes for these soldiers? So, other things that nursing research does help us to do, all right, they help us identify those specific nursing interventions that are proven effective and not just based on tradition, right? We don't like we don't want to continue to go with, this is the way it's always been done, right? What are the hard facts? Why do we do what we do? Why do we turn and reposition our patients every 2 hours? Why is inserting a Foley catheter a sterile procedure? Why do we do chlorhexidine baths, right? So every action that we perform, every intervention that we provide for our clients needs to be evidence-based. It also provides evidence that supports the quality and cost effectiveness of what nurses do. And it also generates knowledge for clinical practice, nursing education, and how we deliver our nursing services. Okay. Nurses of all levels, from LPN to PhDs and DNPs, whichever, everybody is encouraged, okay, to participate and promote nursing research. Okay. So don't think, oh, I won't ever do that, because you just never know. Um, I feel like I'm sorry, I must have been mouse happy because I skipped a couple slides. So in in nursing research, there are two main types of studies or two types of research studies that we do. There are many other different types of research studies, but these are the two primary ones. We have our quantitative research studies. Quantitative research studies are objective studies. So you can even think of when you think of collecting objective and subjective data. Objective data is something that we can quantify, right? So quantitative, objective. It's during a quantitative research study, a variable is the event that they are trying to measure. Okay, there are two types of variables. One variable is the group receiving the intervention, and the other variable is the group that does not receive the intervention. So if you go all the way back, maybe to pharmacology, um, um, and you look at that FDA approval process for medications. I'm just going to go there. So we have a new antihypertensive medication that just is, we're getting ready. We're starting to do our human drug trials. Okay. So we want to see how effective this medication is, right? So we get a group of people and we
That's what
split
I
them
was
up into
saying.
two
My baby,
groups.
you gonna put your phone on
All
you.
right. So we have One group over
I'm about to
here.
watch it.
Ashley, can you mute yourself, please?
I'm sorry.
We
Still,
have two groups. The group over here, we're going to give them the new drug. Okay, so they're going to get the new antihypertensive drug. And the group over here, they're just going to get whatever the current drug is on the market. Okay, and then we're going to compare. All right. We're going to compare. So it's numeric data that we are comparing. Okay, and we'll use statistics to describe those variables. Okay, that's your quantitative data. The randomized control trial, that is the recommended type of quantitative research. Again, we have two groups. One gets the intervention, the other one does not, and then we are going to collect data and compare the two groups. With a qualitative research study, qualitative is subjective. We are not getting any concrete data, okay? Data is collected by interviews and or direct observations, but it is a study of the narrative description of lived experiences. Okay, so the example here is chronic pain. So we are going to get a bunch of people who are all dealing with chronic pain, and we're going to perform interviews and we want to get their lived experience. This is subjective, right? Because what is it? People are telling us this information, right? So it's completely subjective, right? And not everybody's experience with chronic pain is going to be the same. Okay. So we literally are just collecting this information. We may recognize there's some patterns and things, but it's not, something that we can quantify. When we look at phenomenology, this is a type of a qualitative study. Um, and so it is an occurrence or a circumstance that the researcher studies. So this example here is a case study examining the lived experiences of high school students who are both gifted and diagnosed with ADHD. Okay. So we're gonna get see if we can find a bunch of kids that are ADHD and also considered gifted. We are gonna interview them, right? And we are gonna get their experiences. And everyone will have a standard list of questions, and that's fine. But again, everybody's answer is going to be their own. So sorry, quantitative. Is objective, right? So we're going to collect data. And then qualitative is subjective. All right. So when we look at these research studies, more so the quantitative, right? We're collecting data to help determine what best practices are. All right. And so everybody, I'm sure, have heard the term evidence-based practice at some point in their educational journey here. And so Dr. Archie Cochrane, he was a British epidemiologist. He challenged, and we haven't talked about healthcare financing yet. We'll talk about that next week. But he challenged the public to pay only for medical care that was proven to be effective. Okay. So not just, oh, we're going to see if this helps, or well, maybe this will help, right? We want the care that is proven to be effective. He advocated for those randomized control trials as a means of reliably informing healthcare practice. Again, remember, one group is going to get the intervention, the other one is not going to get that information. And then he established the Cochrane Comp.
Can you show her those two that I just sent her?
Linda, can you mute yourself and turn your camera on, please? Okay.
I'm sorry.
Okay. So again, the Institute or Cochrane collaboration was established to prepare and promote the accessibility of Cochrane reviews. And again, he was promoting best practices. So it's just a collection of evidence-based healthcare interventions that have been obtained by doing what's called systematic reviews of research. So a systematic review, right? And we'll talk about this in a minute, but let's say you're curious as to why we, you know, wash our hands. Okay, we're just going to go with that. All right. And you can go and you can do research. And so you can go to the Cochrane Reviews, you can go to any online library or other resources. All right. And you can do research, and you're going to probably find a whole lot of articles about why we wash our hands. Okay. But a systematic review is basically we're going to take a bunch of articles all about the same thing. We're going to review and determine what the best interventions would be. So again, why we wash our hands, why we turn and reposition our patients every 2 hours, right? A lot of the foundational stuff for the things that we do in nursing is based off of research. So this was actually really foundational. So in 1999, the Institute of Medicine, they issued a report. It was called To Err is Human, Building a Safer Healthcare System. All right. And so again, this was back in 1999, so it was a little while ago. It discussed the incidence of medical errors in healthcare and the need for reform. So it estimated that there was between 44,000 and 98,000 deaths annually in the US hospitals as a result of preventable medical errors. Huge number. Like, that's a huge number. Um, and so the financial impact was up into like almost $30 billion for these. So this brought to light a lot of issues within the healthcare system. And so then in 2001, they issued Crossing the Quality Chasm. Okay. And so when we look at the that too many big words apparently for me. Um, Crossing the Quality Chasm, a new health system for the 21st century, called for consistent, high quality healthcare for all people. And included in that was patients should receive care based on the best available scientific knowledge. Okay. So that was another big push, right, for evidence-based practice in how we provide not just medical care, but for nursing care as well. And as a result of these studies, especially with the first one, a lot of changes were put into place. We do, of course, we already know we have like the rights for medication administration, identification of our patients. They do what are called, I think I don't know if they're surgery timeouts or procedure timeouts or whatever it is, right? But they actually do a timeout prior to performing a procedure. They identify the patient, they identify the site the surgery is supposed to be on, right? So they do this timeout to try to prevent errors. And there's a lot of other things that were put into place. They did a follow-up. Um, they did a follow-up in, I don't remember what year it was. Um, it was like, I don't remember if it was 2000, if it was 2009 or if it was 2019. But there was a follow-up. And they did I forget, like I said, and there's still significant areas that we need to focus on to prevent medical errors. Now, again, a lot of them were medication errors, not all of them, but a lot of them were medication errors. I don't know why my slides are acting silly. Okay. Um, and then in the last 20 years, insurance companies began to pay for health practices only if effectiveness is supported by scientific evidence. Okay. So again, can't just order tests willy-nilly, right? We need or perform procedures, medications, all of those wonderful things. We have to have some sort of scientific evidence backing them to ensure their effectiveness. And then in the last decade, we've had a big push for more of the um, quality of care. So hospitals are denied payment when complications in a Medicare client develop if evidence-based guidelines are not followed. Okay. So again, big push more towards quality of care versus quantity of care, right? Preventing injuries, preventing accidents, preventing pressure areas, infections, right? We're really pushing for that quality of care. And our patients are becoming more informed. They are, hitting up Google, right? They are seeking the latest evidence on websites about the most effective treatment for illnesses and diseases, right? So a lot of times when they are seeking healthcare, they've already done a lot of research, okay? And they're going to come in well prepared, right, to suggest, some options for their care. Not necessarily a bad thing. We just need to make sure that they are getting their information from the appropriate sources. All right. So how evident or how best evidence for practice guidelines are determined? All right. So it is a very rigorous process. All right. So the first part of it is what is the clinical question being investigated? All right. So we are going to formulate this question in an objective, concise manner. All right. And so a lot of times they will use something like a PICO format or another format to develop their clinical question. All right. So um, let's say, I'm trying to think of a good example. Let's say, I don't know, maybe we have a client who, um, well, I can't think of one all of a sudden. Um, all right, I'm gonna use pressure areas. Maybe we have a client that has a stage 3 pressure area. Maybe it's not healing as well as we would hope it was or hope it was. Okay. So the clinical question would be related to pressure ulcer healing or treatment. Okay. And then we are going to use professional resources. All right. So we're going to hit up the library. All right. And we are going to look for the latest, most relevant research evidence that pertains to that clinical question. Right. So when we look at latest and most relevant research, this is within the last 5 years. Okay. 5 years is pretty much as far back as we go for current. All right. There's lots of different places. You can go to PubMed, you can do Medline, which is part of PubMed. You can do CINAHL. CINAHL is Index of Nursing and Allied Health Literature. Of course, you have the Cochrane Review, like we also looked at or we talked about earlier. AHRQ, which is the Agency for Healthcare Research and Quality. Trying to think, you have Joanna Briggs Institute is another one. I'm trying to think if there's so many out there but you can go to your online library. A lot of your hospitals, especially the bigger hospital systems, they will also have online libraries that you can use to do research. And so again, you're going to do research on whatever the best practices are for wound healing. Okay. And you're going to get a bunch of articles from doing that research. And then an expert or a panel of experts are going to get all of those articles that, they found or you found, and they are going to do that systematic review. Okay. So they're going to look through all of those research articles. They are going to develop that summary or that systematic review. And from that systematic review, because it's all research that's already been done and completed, that is when the guidelines are going to be determined. Okay. So using critical thinking skills, that evidence that you collected during that research process is going to be combined with their clinical expertise or experience and clients' preferences, and then we can implement those. So I don't know. I mean, I'm just going to say, we already know turning and repositioning. I don't know. Maybe there's for whatever, so maybe he needs to have some what do you call those? I was going to say bariatric, and that's not the right word. Um, I can't think of the word. It's kind of embarrassing, but let's just say whatever. Maybe there's a new cream or there's a new medication out there to treat those pressure areas. And so you're going to take that information, you're going to sit down with the client, and you're going to discuss it, and then you can use it in that patient's care. So again, just to reiterate, get all that information that we did from our research and doing the systematic review. And evidence base is three elements. So you have your best research evidence. Okay. Again, did all those, did those review of those articles, your clinical experience or the nurse's clinical experience, and the client preferences. Those are the three big parts of your evidence-based practice, right? So we can get all that research, right? We can develop that, those, you know, interventions to put into place based off of the experience of the nurse and what does the client prefer. Um, so I told you nurses at any level can be involved with nursing research. So there's research doctorates. Those are your nurses that have the wonderful PhD at the end of their name. They're the ones that design and implement research studies and publish their findings, right? So they're going to go and they're going to establish what those best evidence or best practices are. The nurses with a practice document or doctorate, sorry, those are like your DNPs, which hopefully one day I will finish my program and I will have my DNP, okay? But DNPs review present research and formulate evidence-based protocols, okay? So we do research and we develop those evidence-based protocols. At the master's level, they can formulate questions. They can also evaluate the effective evidence-based solutions on nursing problems. Okay, bachelor's degree can also identify questions, critique research, use evidence solutions to nursing problems. Your associate degree or diploma nurses can challenge the status quo, question assumptions, offer new insights to improve the quality of care. And then at the practical and vocational level, right? Question the basis for nursing actions by considering research, evidence, tradition, and client preferences. Pretty sure I said this before. You guys are going out into the nursing workforce. You have fresh eyes, okay? So this is where you may identify things that need to be changed, things that could be done better. All right. So we don't always just accept things anymore as the status quo. We're always looking to do better, right? Provide better quality care for our clients. And a lot of it's going to be based off of research. And that is how that evidence-based practice is developed. So again, question, right? You always want to go in with that questioning attitude, right? What can we do better? How can we do it better, right? the spirit of inquiry is always such a big part of that. Okay. Um, and so you're going to raise questions, you're going to challenge tradition, you're going to, in those existing practices and see creative approaches to problems. So you can, review current articles in professional sources. You can, support nursing interventions on care plans and in practice with evidence-based nursing. But again, you guys are going out there with fresh eyes. You may be the ones that change the whole nursing world. So don't ever stop questioning. And again, that's that spirit of inquiry. Okay. You raise questions, you challenge tradition and existing practices, seek creative approaches to problems, right? Having a fresh set of eyes, for any nursing students that, nursing graduates that go out into practice, right, only has the potential to make things better. So don't just accept the status quo. If you, think something can be done better or it can be done more effectively, then do some research. I've, talked to um, hospital managers that hire new grads. And again, it doesn't matter if it's an RN or an LPN. Um, they want to, to help them find better ways to do things. And a lot of the ones that I've talked to, they, like I said, they have um, libraries and, access to information. So you can, even ask sometimes the librarians will be able to help you look at what's the word I'm looking for, help you to find some information, and use it, do that research. No, I'm not going to say research is the most fun thing in the world to do. Because every week when I'm writing my papers for school, I I'm like, oh, why am I doing this again? But it really is something that is really important. It is something that you really should, at least especially to keep up with your practice. You want to try to dive into and see what those real, evidence-based interventions are for your clients. All right, so any questions on theory? We're going to dive into critical thinking here next. Critical thinking is always the fun part, and then we'll probably have time after that to do some practice questions as well. But does anybody have any questions? All right, so let's take a break. Be back at 3:10. Okay, go. Sorry, there's, a leaf blowing outside. So that means that my dogs have to start barking at the leaves because, something is moving outside. All right. So let's start the wonderful discussion about critical thinking. And so again, critical thinking is going to be chapter 5 in your Success in Practical Vocational Nursing book. So we look at critical thinking. Um, there's 10 top, or there's top, what is it? The top 10 reasons to improve thinking. And I will share my screen. And these have been adapted for the practical nurse. All right, so share my screen. Again, these are the top 10 reasons to improve critical thinking. All right, so the first one, things are not what they used to be or what they will be, okay, in the changing healthcare system. Okay, things, and I can say this because I've been around the block a couple times. All right, it's not, nursing isn't the same now as it was when I first started nursing, even as an LPN way back in the day. Um, LPNs, LVNs frequently care for clients as a member of the healthcare team who are not yet stabilized and have multiple problems. Okay. So I'm going to apply this really to long-term care. Okay. Um, the primary nurses in long-term care are going to be you as LPNs, right? LPNs are very prevalent in long-term care. All right. And, even though there are RNs that work in long-term care, okay, LPNs are still the majority. All right. And so you are going to work with clients that have multiple chronic conditions, acute conditions, right? They may not always be completely stabilized. And I use an example. There was LPN, she was an LPN charge nurse. And we got a new admission to the facility, right? Normal get admissions all of the time. And literally as they were transferring him from the stretcher to the client's bed upon arrival. He declined rapidly, and they had to code him and then call an EMS and have them bring them right back to the hospital. Okay, so again, you are going to take care of clients that may not be stabilized. Um, More clients and their families are involved in healthcare decisions, right? Healthcare literacy, internet access, right? They have a lot more knowledge. They are going to be more involved. LPNs must be able to move from one healthcare setting to another. Okay, so whether it's working in the hospital, working in long-term care, right? Whatever it is, you need to be able to move from one setting to the home care, right? Rapid change and information explosion requires LPNs to develop new learning and workplace skills, right? That is one thing about healthcare. It is ever changing. It is ever expanding. We have new practices, new interventions, everything that is, policies, procedures. Clients, families, and insurance companies demand to see evidence of benefits, efficiency, and results of care given. Again, this is that big push. It's not about the quantity of care. It's about the quality of care can't even say it of care. Okay, so you can be in and out of that client's room 100 times a day. All right, but if you are not providing that client quality care, okay, then what are we really doing? Today's progress often creates new problems that cannot be solved by the old ways of thinking. Okay. So think about some of the ethical and legal issues involved in end of life decisions. Questions about stem cell research is always going to be a big one. Who is entitled to receive expensive medical care? We also have redesigning care delivery and education programs is useless if students and nurses don't have the thinking skills required to deal with today's world. Learning how to improve your thinking skills does not have to be difficult. Okay, that's always a big one. And then number one is your ability to focus your thinking on how to get the results you need can make the difference between whether you succeed or fail in the fast-paced healthcare system, right? I know critical thinking has been a topic probably since day one of your nursing program, right? Talk about developing those critical thinking skills. And each class that you take in nursing school expands on the previous class, right? Anatomy and physiology, those were your foundational courses. Without anatomy and physiology, you really can't understand a whole lot of the disease processes and how they all interlink together, right? Kidney disease doesn't affect just the kidneys, right? It affects a lot of other processes in the body. Same thing for the liver, the heart, right? Or even the brain. All right. So you've heard about critical thinking since day one. And again, we've helped you, hopefully, you've had help in developing critical thinking skills throughout your nursing school career so far, right? And again, each class is going to expand upon the previous class. So being able to put all of the pieces together. I always used to say that nursing school is like building a puzzle. Okay. Each class, you get pieces to the puzzle, right? Some classes you get more pieces to the puzzle than other classes do, right? And then by the end of nursing school, you have this big puzzle that you have now put together, and you have to be able to relate to how those parts all fit in with each other. So, critical thinking. And so we look at critical thinking. It is related to the nursing process, and that's how we teach you, right, to think critically is by using that nursing process. It is also used in clinical judgment. And as a future LPN, okay, you will be expected to be an active learner and a critical thinker, Um, it, critical thinking is also guided by professional standards. Okay, so think of NAPNES, and then of course your NALPN, your Nursing Code of Ethics, right? These are all part of that critical thinking process. So ways of thinking or definition of applied critical thinking, it is purposeful, informed. It is driven by client and family needs. It is based on the principles, like I said, of the nursing process and based on knowledge, skills, experience, and the nursing code of ethics. It is logical and intuitive. It is guided by professional standards. So, like I said, you have your NAPNES and you have your NALPN, and it is constantly reevaluating and striving to improve. Okay. As you continue to, even as you finish, nursing school, okay, and you go out into practice, your critical thinking skills are going to continue to improve. But critical thinking is an advanced way of thinking, okay? It's a problem-solving method. We use it to resolve problems. We also use it to find ways to improve a situation, even if a problem doesn't exist. Okay. So you're going to collect data, you're going to analyze that data to make a decision, right? Things like, how can we do this better? How can we, help that client achieve the highest quality outcome? What resources are essential? What resources aren't so essential? Can we, eliminate those to potentially save costs? So different thinkings, is that the way I want to say that? We think thinking itself, I guess, is divided into non-focused thinking and directed thinking. All right. And so most of us have used these types of thinking. So non-focused thinking. All right. Um, you engaged your brain out of habit without much conscious thoughts, right? Um, whatever it is, right? Whatever that process is. Habitual thinking, everybody does habitual thinking, whether we think about it or not, right? We get up in the morning, you go use the restroom, you take a shower, you get, do your hair, do your makeup, you get dressed, right? All of those wonderful things. This type of thinking and, involves any type of routine that we do. All right. We don't have to think very hard about doing these because it's a habit, right? Then we have random thoughts. These are multiple short scenes and thoughts that come and go through the mind. They have no particular purpose or goal. So it's like your mental challenge, channel surfing, which you may even be doing while I am lecturing to you now, making your um what do you call it? Like your grocery list in your mind or thinking of all the things that you have to do, right? Gotta go to the grocery store, gotta pick up the kids. Maybe there's a birthday party or I got clinicals tomorrow, right? It's just those things. Ruminative thoughts, the same situation or scene is replayed in the mind over and over without reaching an outcome. So it's like an instant replay. All right. So you're watching a baseball or a football game, right? You can watch the instant replay. All or none thinking, the mind is made up and no additional facts will be considered. Okay, so this is like it's black and white. There's no gray in between. It's either all or nothing. Negative thinking, the mind is stuck on negative thoughts and blocks worthwhile thinking. Okay, this is emotional sabotage. All right, I think of negative thinking, like ever have an argument with somebody or even just a discussion with somebody, and you leave that discussion or you leave the argument and you're like, oh, I should have said this, this, and this. Okay, you really don't get anywhere with it because you can't go back and replay the whole situation, right? You can't call them up and say, hey, can we have this argument again? Right? It's not doing you any good. Directed or focused thinking, this is your purposeful, your outcome oriented thinking. And then your problem oriented thinking. Okay. This focuses on a particular problem to find a solution, right? So you're going to sit down and you're going to say, okay, here's the problem. All right. I have three kids and they all have a game at the same time on Saturday morning. And how am I going to get them to three different fields all at the same time? Right. So you're going to sit down and you're going to try to figure out how am I going to do this? Right. Usually you're going to employ some help. Okay. But that is what your problem oriented thinking is. I already said this one. Critical thinking is an advanced way of thinking. It's a problem-solving method. It's used to resolve problems, find ways to improve a situation, even when there's no problem existing. It involves collecting and analyzing data to make a decision, and it answers questions like, how can we do this better? How can we assist the client in achieving the highest quality outcome? What resources are essential? And which can be eliminated to save cost. So, it involves questioning with meaning. And so, got to make sure that when we are asking questions, we have meaning to those questions. Judgment that is made on facts, not assumptions. Okay. So we always, talked about that, right? We don't make judgments, just based on observations. We want to have clear, right, facts. We know collaboration is a key to effective thinking. Who do we need to collaborate with, right? Is it the RN? Do we also need social work? Do we need therapy, right? Collaboration is a big part of everything we do. Remember, nursing is an individual sport, it's a team sport. Always use that nursing process. And then decisions are based on the right thing to do rather than emotions. And so there is box 5.1 in your textbook. And it is just a um, ways to challenge yourself to think critically. You don't have to do it, but it is something that you could look at that will help you. What influences our critical thinking? This is always a big one, right? What influences you? And it's, think of these things can influence all aspects of your life, right? Not just your critical thinking, but your upbringing and culture. Okay. Um, what was your upbringing like? Did you have family and teachers that supported you, that provided you opportunities to learn, not just to read, but to understand what you're reading, making, choices, right? Being able to deal with, choices that become a little bit more, um, complex as we get older, your motivation. Okay. Um, this is always a big one. You have to have the motivators, right? Um, what is your motivation, right? Do you have the ability to think critically if you choose to do so? All right. It is a preference on your part. It may, take a little bit extra practice for some, but you do have the ability to think critically. And the more you use the brain, the better it works. And then your attitude. Attitude influences thinking, whether you believe that or not. Okay. Critical thinkers are more humble. Okay. They recognize that they don't have all the answers. Okay. And these also can be influenced by beliefs and values. And so again, realize that, you know, even after, as long as I've been a nurse, doesn't mean that I have all the answers. Okay. I still do research. I still look. I always want to make sure that we're providing the best care that we can for our clients. Um, while taking care of our clients, right, it does make a critical difference whether a problem is recognized, missed, or ignored, right? If we recognize a problem, we can put into action the appropriate interventions to address that problem. If we miss the problem, all right, and we don't put the appropriate interventions in for that missed problem, right, there could potentially be some negative outcomes. And same thing if we ignore the problem. All right. The patient is, you know, um, saying something and you're continuing to ignore that particular problem, it could result in some negative outcomes. So we always take the time, right, to collect data on your attitude. Okay. And there's exercises that you can do, you can use. They're in the book. And it's just asking, and it's a personal evaluation, and you can take the personal evaluation and kind of see how you fall. Always with personal evaluations, right? It's your level of honesty. How honest are you with yourselves when you're looking at your attitude? I just saw this. Jamalatu and LaShawn, if you can turn your cameras on, please, that would be awesome. Linda.
Yeah, I ain't turning it off.
All right. Um, so other things that affect our critical thinking. Effective reading. Okay, this is a big one. Um, when you're reading, right? It's not just being able to read it as fast as you can just to say that you read it, right? How much do you understand what it is that you're reading? Okay, what is the significance? How can we use the information that we are reading, right? So if you're looking at, research and you're trying to figure out, right, what the best practice is, you have to be able to understand what it is that you're reading. Effective learning skill also means that you're able to organize data, right, that you have so you can access them efficiently, right? So when you're collecting all your data from your clients during that initial interview process, you need to be able to organize it appropriately so that you know exactly what you're looking at. Your maturity, okay? Um, Maturity often does come with age, but I will say age does not determine maturity. Okay. So age is not the primary determinant of maturity, and I'm sure everybody has, seen that in some people. Maturity provides past experiences where you have worked through problems, right? So that helps us to mature. And, sometimes as we mature too, it becomes easier to see problems through somebody else's eyes. Problem solving in the nursing process. All right. So knowledge of problem solving and the nursing process is based on some of the same principles that, or some of the same critical thinking principles, right? So when you work out your problems, is it a problem solving step process that you use, or is it, you just, this is my solution and I'm going to go with it. Your communication skills. Can't say enough about communication skills. Can't say enough about communication skills. Communicating effectively means being aware of the message that you are sending, whether it's verbally, whether it is written, whether it is through your body language. All right. So, are you willing and able to listen and consider ideas and views that are different from your own? That's always the big one. Um, your self-confidence. All right. Self-confidence is often the one personal characteristic that is the least available, especially in a student. Why? Because you're learning. You may not be confident in making those clinical decisions yet. All right. However, okay, if you don't have self-confidence, right, then you worry that you may not be able to get it or perform it or do it. All right. Nobody can give you self-confidence. Okay. You develop self-confidence as you succeed, right? So, you need a daily dose of self-confidence, let me know, but I'll give everybody one. Look how far you have come, right? You're in your last term of nursing school, so you have made it this far. And in 4 more weeks, right, it'll be over and you'll be done. And you'll be able to go and study and pass your NCLEX and go get a job, work and go back to school, whatever it is that you want to do. But always, you know, self-confidence is earned, it is not learned. Nobody can learn you. Nobody can teach you to be self-confident, right? You develop that on your own. On the other hand of that, though, we want to avoid overconfidence. Okay, so overconfidence can make people assume they are correct even before they can be proven to be correct. All right. So we still have to, you want to find that nice little happy medium in the middle. All right. What else? Moral development. Moral development creates fair-mindedness, a strong sense of what is right and wrong. And so talked about this. I don't remember what week it was, but really sitting down and doing a self-examination, right? What are your, values, your morals? Can you separate them from the values held by others? Okay. And we talked, I think it was last week when we talked about like finding the perfect job. And I said, always look at the mission statement to see what the mission statement is, right? Does it fit with your personal values? And if your values align, then that's great. But if you don't think that they do, that's probably, right, not the best place for you to go and become employed. Your capability in nursing. So obviously we know capability in nursing is absolutely essential. Okay, you have to have the nursing knowledge and the skills to do the work of nursing, and how to access resources, right? So where you work is going to determine what resources are available to you. Distinguishing what is absolutely necessary to know from what is nice to know is also something that you have to look at. Um, so always think, how capable are you in doing what you are doing? All right, collaboration. I know I've said this a million times. Nursing is not an individual sport. It is a team sport, okay? And so the collaborative effort too has been shown to promote critical thinking skills. And so I don't know how many of you, while you guys are on campus and campus offers different programs, sometimes even getting to know, you know, members of the other, what am I trying to say? Like if you have medical assistants or what else? Dental assistants, massage, any of the other disciplines, dental assistants sometimes as well, right? Getting to know them and what their role is in healthcare, sometimes can also, right, help to kind of build your understanding of what they do in that collaborative effort. Anxiety. Um, so when your anxiety levels are overwhelming, it stops critical thinking. Okay. If you are, extremely anxious or even tired, okay, your critical thinking ability is decreased. All right. It stops critical thinking. And so we have to be aware of this both in practice, right? Yeah, it's nice. I was gonna work my 412s and I don't have to work for another week, right? Sounds great, right? But how is that affecting you mentally and physically? And then your mentors and experience in nursing. So one thing that I always recommend, whether it's somebody that you work with or it's somebody that you meet when you start working in your, new position, is find a mentor, somebody that's been working for a while that knows the in and outs of the area of nursing that you are working with, and get them to mentor you. That really will help, assist you with learning, developing critical thinking, clinical reasoning skills, identifying patterns, right? All of those wonderful things that you're going to need for your for your nursing practice. So you guys do now raise your hands. Or maybe I don't know if I want to know the answer to this question. I'm going to ask it anyway. Raise your hand if you read the comments that I put on your NCLEX questions. Aw, okay. I don't know if you're being on. No, I'm just kidding. So why do I do that?
Positive feedback or negative feedback.
I try not to do negative feedback. I
Well,
really
critical
try. Yes,
still.
I try to do as critical as possible. I try not to be negative. But um, so I do that because, all right, when you look at your NCLEX questions, okay, and I don't think I have any, but I'm gonna look real quick while we're talking. The reason why I do that is because the NCLEX is broken down into these cognitive levels, okay? And if you look at your, um, I'm trying to multitask and apparently my brain is not allowing that for me to happen today. But if you look at your NCLEX questions, it also breaks these down. And you can see where some of the areas that you may have that were a little bit weaker. So I was trying to see if I had any results, and I I've done some. For some reason, it is not populating. So never mind, I won't show you one. Um, I was gonna try. Um, but knowledge, okay? So when we look at knowledge, all right, give me 1 second. All right. So knowledge refers to the ability to recall and repeat information that you have memorized, okay? Memorizing is not the same as understanding, so be aware of that, okay? So knowledge is the lowest level of learning, all right? So an example of knowledge would be what is normal potassium levels? Okay, what is a normal level for potassium? That would be a knowledge, all right? It's something that you've memorized, and probably we've repeated that 1,000 times, right? So that is an example of a knowledge. Comprehension is a basic understanding of information, the ability to recall it, and identify examples of that information. All right. So you got understand the meaning of the material. This is the lowest level of understanding. So this is the ability to repeat something in your own words. Okay, so almost like paraphrasing, right? You can repeat the information in your own words. That means that you understand that information. Application is using what you learned and, in new situations. Okay, so you're sitting in class in, let's say, med surge, okay, and learning about heart disease, okay, whatever, whatever the topic is, okay. And then you go to clinical and you have a patient that has heart disease, right? So you can apply what you learned in class to what you are doing in clinical. So application also it includes being able to prioritize or determine what is most important, what comes first, right? We've talked about prioritization of care. This is the highest level of understanding. So you must be able to use knowledge to tailor those approaches depending on what the circumstance is. And then analysis. Analysis means breaking down complex parts and relating them to the big picture. Okay, so this is the ability to organize and prioritize what is more important, what is more urgent, can't say the word urgent. Um, and so this is a higher level of application. So being able to identify the most important symptoms that a client with a specific problem has, right? So what is your response, right? So, all right, I'm going to ask a question. So you walk into a patient's room, they're laying in bed and they're complaining of shortness of breath. What is the first thing that you do?
Elevate the head of the bed.
Elevate the head of the bed, right? We haven't done anything yet, right? We haven't gotten to pulse ox. We haven't listened to their heart, right? Or their lung sounds, sorry, right? We saw them, they're laying in bed, they're short of breath. So the first thing we know, right? It's ingrained in our brain that the first thing we do is elevate the head of the bed because that's going to facilitate breathing. Okay. So this goes back to why I break down your NCLEX questions like I do. All right. This helps, all right, as you are studying, because like I said, NCLEX PN, that big test that you're going to take when you graduate from nursing school. All right, these are the topics on your NCLEX PN. Does anybody, and you know what? I just realized, I don't know. I think I did, but I could not. But I could be wrong, and I will ask this question. Did I show you what the NCLEX test plan looks like? I did not. Okay, so we will do that next after I finish these last 2 slides or 3 slides. So we look at all what I just said, and I'll pull that up while I'm talking. Comprehension, application, and analysis are what employers expect of an LPN on the job. Okay, so you need to be able to comprehend, apply, and analyze situations. All right. Instructors also expect that level of competence, especially in the clinical area, as you are especially transitioning to practice. The LPN is also responsible for many of the judgments and decisions made in healthcare. So remember, you guys are going to be frontline nurses. You're going to have to be able to recognize trends and make sure that you are applying those critical thinking skills, and a newly licensed LPN is increasingly required to make more complex decisions about clients. And I kind of said that a little bit earlier. So let's put it together. All right. So we have a 54-year-old male. He was admitted this morning with lower back pain. He has a past medical history of heart failure treated with digoxin, furosemide, and metoprolol. His vital signs are normal. He doesn't have any allergies. He is a full code. He has had a CBC and a CMP drawn. He has a critical lab value that was called to the nurse, which was a potassium of 3.2. All other lab values within normal limits. Okay, so the LPN calls the physician with the critical lab value. What orders does the LPN anticipate and why? All right. So let's go through this first, right? We have 54-year-old male. He was admitted with lower back pain. He is history of heart failure. He is treated with digoxin, furosemide, and metoprolol. Tell me about digoxin first. What is digoxin?
Isn't it a negative inotropic?
Oh, we're using big words. Okay. And what does that mean?
I know you lose potassium when you're on it.
Not with digoxin. Not with digoxin. You don't lose potassium with digoxin.
Digoxin's a heart medication.
It is a heart medication. It is an inotropic. So what does that mean? What does it do?
It
Does
reduces
it?
the contractility.
There you go.
Yeah.
Yes. So we use it for patients that have heart failure. Okay. So digoxin used to treat heart failure. We can also use it to treat other things like AFib. Okay. So when I have heart failure, okay, what happens? My heart is not able to pump blood effectively, right? Which means that I'm not getting oxygen and nutrients to my tissues, okay? So that means that what? My heart has to work harder, okay? So if that's, of course, we know there's right-sided and there's left-sided heart failure, okay? So either side, but eventually what ends up happening is that both sides are going to fail. But that left ventricle, okay, it's trying its best to get blood out. So maybe my heart rate's 100 because it's trying to get blood to the tissues because all those, neuroreceptors are coming back saying, hey, we're not getting enough oxygen and the heart's just going to keep pumping. So digoxin, like you said, it's a non-tropic drug. It's going to slow the heart down. Okay. And it's going to give us a better pump. So it helps the heart beat stronger and more steadily. All right. So instead of 100 little beats, 100, little pumps of blood, maybe we're getting 80 good pumps, right? We're really getting that blood out. It does affect sodium and potassium because of that sodium potassium pump, right, for muscle contraction, but it doesn't generally have an effect on the levels. Okay. Tell me about furosemide. What is furosemide?
Lasix.
It's diuretic.
Okay, it's Lasix. Dominique, say that again. I'm sorry.
Loop diuretic.
Yep, it's a loop diuretic. So loop diuretics are the most potent diuretics that we have out there, right? It's gonna pull off a whole lot of fluid. What are some concerns about taking furosemide?
Maybe losing potassium.
Very good. It is not potassium sparing. So in patients that are taking furosemide, they're going to lose potassium. Okay. Now, okay, we talked about digoxin, we talked about furosemide. Now, somebody kind of said it earlier. What is the problem with taking both of these drugs together?
They both affect the potassium levels.
Okay. So, furosemide is going to cause us to lose potassium. Okay. Hypokalemia or low potassium level increases the risk.
For cardiac dysrhythmia.
Well, hold on, because I'm talking about the meds right now. With if I'm losing potassium, that is going to increase the risk for digoxin toxicity. Okay. So for whatever reason, okay, um, because of that sodium potassium pump and then all of the, the interactions that can occur, it, like I said, that low potassium is going to losing potassium is going to increase the risk for dig toxicity. All right. And so when we lose that potassium, the heart becomes more sensitive to the digoxin. Okay. And somebody said, and I think it was Linda that said it, it can lead to an arrhythmia, which can be fatal. Okay. And of course, other things with digoxin too, it can cause, nausea, loss of appetite, and vomiting. One of the big things that we see with dig toxicity is visual disturbances. So sometimes they'll see halos around lights. Okay. So, and then with digoxin as well, is we also have to monitor dig levels, right? So they have to have therapeutic monitoring for their digoxin. And what's metoprolol?
A beta blocker.
All right, so metoprolol is a beta blocker, right? We use it for patients that have hypertension. All right, so got that out of the way. So now we have this critical lab value of potassium, which is 3.2. All right, so what orders should we anticipate that we are going to receive? We're going to call the provider and we're going to give them that potassium
We're
level.
gonna hold the fluorouracil, the Jackson. We're gonna do an EKG. We're gonna get the Jackson level and potassium replacement.
Okay, let's see. So yes, we are going to do potassium replacement for the hypokalemia. Okay, what are normal potassium levels?
3.5 to 5.0.
3.0 to 5.0.
There you go. 3.5 to 5, right? So we're not horribly low, right? But we are a little bit low. So we can do a potassium supplement. We can do oral potassium supplement in this case. Um, we're going to stop the furosemide, right? Because they're losing potassium. We're going to do that dig level, right? Because we talked about the, connection between the toxicity and the hypokalemia. And then if it came back at 2.3, is it no, not normal? I think I'm and then we talked about the signs and symptoms of dig toxicity. So good job. You guys worked through that pretty well. Awesome. Any questions now on critical thinking? No. All right. So we have time to do some practice questions. So let's do this first. So we'll do, let's take a break be back at 4:10 and we'll do some practice questions. Jay Malatu, I need you to go to the breakout room.
Who did you say?
Go to the breakout room.
All of
Me?
us or just
I
No,
did
Chad?
not
just
see
Jay
the
Malatu.
login. I did not see the way to go to the breakout room. How to go to the breakout room? I did not see. Let me just leave the meeting room.
Okay. So I am going to show you what I was talking about. So let me share my screen. I don't know why my share button, there we go. All right. So this is what I was talking about. So a lot of people say, oh, is there a study guide for the NCLEX? There actually is a study guide for the NCLEX. Okay. So if you go to ncsbn.org, or you can just Google the NCLEX test plan, however you want to do it. Just make sure that you click on the correct one. So, oops, that is not it. Go back. Toot toot toot. Click on NCLEX. Then you want to make sure that you get the right one. This is why did not work? Of course, it's not going to work when you're trying to do it. So let me go back. Let me go to Google. Google is my friend. NCLEX. PN test. Here we go. I don't know why that had to be difficult, but here's your NCLEX test plan. Okay, can you guys see it? It's nclex.org or nclex.com, sorry, either way, or NCSBN. You can go either way to find it. But this is basically your study guide for the NCLEX, okay? So if I scroll through here, okay, gives you the background of the NCLEX, and it tells you about the NCLEX. It gives you the introduction, the beliefs, the classification, all that stuff. I am not going to go through every single part of this, okay, but I'm going to scroll through real quick. I'm going to make it bigger because I have old eyes. All right. Here is the test plan structure. And this is, again, this is what you see when you do your NCLEX questions, okay?
Excuse me, Miss Martinez, I have to go off the camera for a second. I have to go downstairs and let my son in.
Okay.
I'll be right back.
Okay.
Thank you.
So this is the client needs categories that you see on your NCLEX questions. Your safe and effective care, the health promotion, the psychosocial, the physiological integrity. And then your integrative processes, your clinical judgment, your problem solving. And then here too, we have the recognizing cues, analyzing cues, prioritizing hypotheses, generating solutions, taking action, and evaluating outcomes. This right here gives you the distribution of content. I like charts. So here's your nice little chart, okay? So it breaks down the NCLEX. It is going to tell you what percentage each one of those categories is going to be on your NCLEX. So physiological adaptation is 10%. Coordination of care is 21. Safe and effective safety and infection prevention and control is 13. Health promotion and maintenance is 9. Psychosocial is 12. Basic care and comfort is 10. Farm is 13%. And reduction of risk is 12. Okay, so that's your 100% of your NCLEX right there, and it tells you what percentages. Okay, so your highest percentages, your psychosocial, your safety and infection prevention, coordinated care, reduction of risk, and your farm. So it gives you all of that information, and I'm going to keep going. And I'm going to scroll down, and it's going to break it down even more for you. Okay, so it's going to break down safe and effective care. It'll talk about coordinated care, and it'll give you all of the topics that are going to fall under coordinated care. Again, I'm not going to read this to you. However, there it is. All right, so you can see. Then it'll go down into safety and infection prevention and give you all the topics that are covered under safety and infection, health promotion, psychosocial integrity, physiological integrity, right? Farm. There's your reduction of risk, your physiological adaptation, and then it'll go into more information, okay? It'll tell you about how long it is. It'll tell you what the passing standard is. It'll tell you about scoring the NCLEX, passing and failing, and it'll just keep going. It'll just keep going. And then again, okay, it is going to give you again some of that sample content. All right, this breaks it down even more towards the end. So there's that safe and effective care environment and that coordinated care, right, that we saw earlier. It's going to break it down even more. Related content includes, but is not limited to. Okay, so it breaks it down even more for you. So all of the things that you need to know in order to take your NCLEX. At the end, you will have a sample question for each one of these little categories. Again, this is your study guide for the NCLEX, okay? So if you feel lost, don't know where to start, don't know what to do, this is the best way to get started. Again, your NCLEX questions, and I know, sometimes it's like, I'm just doing those NCLEX questions to get them done because I need the homework grade, right? 100% understand that, not gonna lie, but, okay, those do help you. The Saunders NCLEX questions are broken down into the same categories as your NCLEX is, okay? And they, repeatedly update those books. So you have this opportunity, just being, an open book here, you guys know the effort that you put into your NCLEX questions, right? You guys know. I do not. I only see what you submit to me. All right. So you have control over that. You also have control to go back and to review the questions, right? That you maybe didn't do some good on, but that is why I provide that feedback. Okay. To say, don't forget to go back, because especially for this class, the management of care, the ethics, the prioritization, the delegation, guess what? You're going to see those again. You're going to see them on your HESI. All right. So that is why I don't do it to say, to necessarily point out your faults. Okay. I just point them out for you, so that you know to go back and to review those questions again and do it as a teaching tool. I'm trying to help you get prepared as much as possible. So for for this week, I'm just going to pull up the Saunders book. I have it, oh my gosh. I have it in study mode. I'm going to go back to the home, and the topics that I chose are going to be content area under leadership and management. I have chosen delegating, ethical, legal, management of care, and prioritization. All right. So maybe I'll take, no, just trying to see if I should take one of those out. We'll just leave it that. It leaves me, if I use new questions only, it leaves me with 99. So we have about 21 minutes. We're not going to be able to do 99 questions, but we are going to do some questions. Now, when we do them, you have the choice. You can either answer out loud or you can answer in the chat. The chat box, the chat is open, so I will see. And as we go through the answering, I will go and I will take the majority answer. And so, all right. And we'll go through the question. We'll do the question. We'll go get an answer, and then we will go through the rationale. So I'm going to share my screen. Again, this is your Saunders book. I just wanted something with a little bit more content in it. All right. So number one, we have the nurse is assisting in caring for a client with a head injury who is restless and pulling at the IV line. The client's physician does not want to sedate the client, and the family has requested that the client not be restrained. The nurse would implement which action? So 1, ask a family member to sit with the client. 2, ask a UAP to monitor the client. 3, stay with the client and consult with the nurse manager about the situation. Or 4, tell the family the application of wrist restraints is critical to prevent injury to the client. This is a good question. I really like this this question. What are we going to do? They're restless. They're pulling at their IV line. What are we going to do?
UAP.
Okay. So I got a bunch of 2s and a couple 3s and a 4. So let me count real quick. So right now the 3 is the majority. So let's see what happens. 3 is correct. Excuse me. So the nurse must stay with the client and consult with the nurse manager about the situation. It may be necessary for the nurse manager to contact the supervisor, oops, went too quick, to obtain an additional staff member to care for the client. Because the client has a head injury, a major concern is the development of increased intracranial pressure. The application of restraints may agitate the client, causing further restlessness and thus increasing intracranial pressure. A UAP is not trained to monitor for increased intracranial pressure. It is inappropriate to ask a family member to sit with the client. Okay, so we are going to stay with the client and then consult with the nurse manager about the situation. All right, that was good. All right. Number 2, a vascular surgeon reported or repeatedly asked the nurse to obtain signed consent forms from the surgeon's surgical client. The nurse is uncomfortable with obtaining the informed consents and explains this to the surgeon, but the surgeon tells the nurse that they will be reported if the consents are not obtained. The nurse would appropriately manage this situation by taking which action? 1, obtain the informed consents. 2, discuss the situation with the nurse manager. 3, contact the National Medical Association and report the surgeon. Or 4, tell the surgeon, I really don't care if you report me, I am not obtaining the consent.
Number 2.
Number 2. Yep, that is the majority is number 2. So let's see, that is correct. Whose responsibility is it to obtain informed consent? Before I hit the
The
rationale.
physician
If
or
conflict,
whoever giving a procedure, like the
there
surgeon.
you go. Absolutely. So if a conflict arises, it is most appropriate to try to resolve the conflict directly. In this situation, the nurses attempted to explain the reasons for being uncomfortable with the surgeon, but was unable to resolve the conflict. The nurse would then appropriately use the organizational channels of communication and discuss the issue with the nurse manager, who would then proceed to resolve the conflict. The nurse manager may attempt to discuss the situation with the surgeon or seek assistance from the nursing supervisor. But yes, it is technically the physician's job or the surgeon's job to obtain the informed consent, right? Because they need to explain the procedure, why the procedure is happening, who's performing the procedure, and all those wonderful things. As nurses, what do? We just witness their signature, right? So if they have additional questions, we cannot answer those questions. All right, next question. A client receives meperidine by the IM route. 30 minutes after receiving the medication, the client's temperature is 101 degrees Fahrenheit, and the skin is warm and flushed with a notable rash on the chest and back. The nurse further assesses the client and contacts the registered nurse, who then contacts the physician. The nurse completes an incident report and accurately documents which: 1, the client experienced an allergy to the meperidine. 2, the physician was notified because the client had developed a rash after receiving meperidine. 3, the client apparently is allergic to meperidine, as noted by a temperature of 101, warm and flushed skin and a rash on the chest and back. Or 30 minutes after receiving meperidine, the temperature is 101, the skin is warm and flushed, and a rash is noted on the chest and back. The physician was notified.
Number 4.
Number 4, that is the majority. So yes, the nurse would document relevant information in an accurate, complete, and objective form. Option 1 does not identify objective data. 3 makes an interpretation about the occurrence, although option 2 identifies accurate information. It is incomplete. Very good. All right. The nurse who works in a cardiac unit reports to work and is told to float to the neurologic nursing unit because of short staffing problem on that unit. The nurse reports to the unit and receives a client assignment for the day from the nurse manager. The nurse is angry with the assignment because of a belief that the assignment is more difficult than the assignment delegated to other nurses on the unit. The nurse would carry out which action? 1, refuse to do the assignment. 2, tell the nurse manager to call the nursing supervisor. 3, ask the nurse manager of the neurologic unit to discuss the assignment. Or 4, return to the cardiac unit and discuss the assignment with the nurse manager on that unit.
3.
All right. All right. Got a bunch of 3s. And that is correct. Yes. Follow the chain of command. If the nurse feels the assignment is more difficult than the assignment delegated to other nurses on the unit, the nurse needs to discuss the assignment with the nurse manager of the neurologic unit. The nurse may or may not have a more difficult assignment than other nursing staff. However, this action will assist in either identifying the rationale for the assignment or determining whether the assignment is actually more difficult. The nurse can't refuse an assignment, but yes, very good. All right. The nurse on the day shift receives client assignments for the day. Which assigned client would the nurse check first? So 1, a client with a diagnosis of ulcerative colitis who is scheduled to be discharged today. 2, a client who is admitted during the night because of a severe exacerbation of asthma. 3, a client scheduled for a kidney, ureter, and bladder x-ray to determine location of a kidney stone. Or 4, a client who had a pulmonary wedge resection 2 days ago and is attached to a closed chest tube drainage system. Right? So which one are we going to see first? All right. 2 seems to be the majority. So yes, the client who was admitted during the night because of an severe exacerbation of asthma. Rationale. The nurse would first check the client who was admitted during the night because of a severe exacerbation of asthma. This client's problem directly relates to airway, and the nurse would need to determine that the intervention administered on admission and during the night were effective. The nurse would next check the client who had the pulmonary wedge resection 2 days ago and is attached to a closed chest tube drainage system. Client's problem also relates to airway. However, there is no indication that the client is experiencing any problems. Then you're going to go to the KUB and all of that stuff. Good job. Very good. A 7-year-old child is admitted to the pediatric unit with an acute exacerbation of asthma due to infection. The physician has written the following prescriptions. In which priority order would the nurse implement the prescriptions? So we got to put these in order. So we have chest x-ray, high Fowler's, clear liquids, O2, and erythromycin. So which one? We have an acute exacerbation of asthma due to infection. So which one are we going to do first? The x-ray, high Fowler's, clear liquids, O2, or erythromycin? Oh, somebody put all the answers. All right, so we're going to do O2 first. All right, what are we going to do after O2?
Wait, so is O2 before you put the patient in high Fowlers?
That's
I
what
would
I'm
do high
asking.
Fowlers first and then
Yeah, I
O2.
would do high Fowlers first.
Okay, so we're gonna do high Fowlers, then O2, then what's next?
Chest X-ray and then clear liquids. POS tolerated and
And then that would leave that.
But you don't think the clear liquids would be after the medicine? Because I don't know. I think that would be clear after you giving medicine because you're giving it with the liquid. So I guess as tolerated, if that makes sense.
Mm-hmm.
But not wet at all. I don't know. That's just how I looked at it. But you could do it that way and we'll see.
All right, let's see. All right, what should we do first? All right, so first we did high Fowlers, we did that. And then two is the oxygen. Okay, so we got the first two right. Then three would have been the antibiotic. So that would have been before anything else. So Fowler's, O2, antibiotic, then the x-ray, and then the clear liquids. So placing the child in high Fowler's first will assist in breathing. Oxygen can then be applied. Administering the antibiotic is the next priority, and then the chest x-ray should not be done until the child has had oxygen in the first dose of antibiotic, and then the clear liquid diet is the last task to be performed.
I don't get why the trying to treat the infection is more important than the respiratory part.
It's not. We're going to do Fowler's, oxygen, then antibiotic.
Before the chest x-rays to make the patient comfortable so that they're not hyperventilating during the chest x-ray.
So we have the acute exacerbation due to infection, right? So you got to remember, right? Especially if we have a pediatric patient, right? Remember, pediatric patients can decompensate much quicker than adult patients can. So, and if they have an infection, we always want to get antibiotics started as soon as possible, right? So as soon as we recognize that there is an active infection, we're going to get antibiotics on board, want to start treating that infection as soon as possible.
Yeah, but
Now,
won't
go
they
ahead.
be have to do the chest X-ray first to see how bad the infection is?
So in this situation, so it's not, so it's a little bit different. Now, if we, let's say, let's change this up. So where it would make a difference, the one dose of antibiotics before the chest x-ray is not going to cause any changes in that chest x-ray. If this was blood cultures, okay, so let's say they ordered blood cultures or any type of culture, then these would be switched because if we give them the antibiotics, that could potentially affect the results of the blood culture. Okay, so they're not going to have a marked improvement in their chest, whether it's pneumonia or whatever. It's not going to improve that quickly that we're not going to get an accurate description or description of what's going on in their chest. All right. The nurse has received a 0700 change of shift report on 4 clients. Which client would the nurse check first? So we have a client admitted with pneumonia 4 days ago who will be discharged later this morning. A client with a head injury sustained 3 days ago who is alert but complaining of a headache. 3, a client with diabetic ketoacidosis admitted 2 days ago whose blood glucose is 180. Or 4, a client admitted early this morning with right lower quadrant abdominal pain and an elevated leukocyte count. Who are we gonna go see first?
Is it for?
Okay, let's see what we got. Majority right now is saying 4. Correct. A client with right lower quadrant abdominal pain would be assessed first because these symptoms are commonly associated with acute appendicitis. A client who is to be discharged does not need to be checked first. The headache is common with a head injury, but the client is alert, indicating stability. A blood glucose of 180 is of concern, but the client's blood glucose was much likely higher on admission and thus is more stable at this time. All right. Several clients are awaiting treatment in an outpatient mental health crisis treatment center. Which client would be treated first? One, a client who is loud, talkative, and pacing back and forth, interrupting others. Two, a client who is crying, saying that their family has abandoned them at the facility. Three, a client who says that voices sponsored by the FBI are telling them to stab their roommate. Or four, a client who is constantly looking over their shoulder saying they're always out to get me. I'm gonna have to take your psych. I'm not a good psych nurse. We got one, we got threes. I think three has the majority, so we'll see. Okay, yes. A client who hears voices telling them to harm others should be treated first. This client has a very high risk of self-harm and harming others. The client who is loud, talkative, and pacing back and forth, interrupting others. The client who is crying, saying their family has abandoned them. And the client who is constantly looking over their shoulder, saying they're always out to get me, do not exhibit symptoms that present a risk of harming self or others. All right. A client will be undergoing a colonoscopy in the morning. Which task is appropriate to delegate to the UAP? So one, witnessing the client sign the procedure consent form. Two, determining whether the client has understood the instructions given. Three, entering the call light promptly after an enema has been given. Or four, ensuring that the client has consumed a soft diet the evening before the exam. All right, got three. All right, three is correct. Yes, right. They can't witness the signing of the consent form. They can't determine whether the client understood instructions, and they can't ensure that the client consumed a soft diet the evening before, but they can answer the call bell promptly. All right. A client with severe preeclampsia is admitted to the maternity department. Which room assignment is most appropriate for this client? One, any available room near the elevator. Two, room farthest from the nurse's station. Three, private room within sight of the nurse's station. Or four, first available room across from the nurse's station. I'm going to go with your OB experience here. All right, I'm going to go with three. That's the majority. That is correct. So a quiet room in which stimuli can be minimized is most important. So a private room within sight of the nurse's station is the correct option. The client will require constant monitoring, so the room farthest from the nurse's station is inappropriate. From the remaining options, rooms across from the elevator and the nurse's station have a high traffic flow and noise would therefore be inappropriate. All right. Let's see. I think we can do one more. A client in labor is experiencing dystocia. In delivering care to this client, the nurse would place the highest priority on which ongoing nursing intervention. One, coaching and supporting breathing techniques. Two, monitoring the status of both client and fetus. Three, educating and updating family members about the progress of labor. Or four, providing comfort measures, change of position, emotional support, and touch. Again, I'm going to have to leave that one to you because it's an OB question. You guys have more recent OB experience than I do. All right, I'm going to go with two. Yes, that is correct. All of the options represent correct nursing actions, but the highest priority is to monitor the status of the client and the fetus. This option is the one that exemplifies the most urgent physiologic need and as such takes precedent over the other nursing interventions. And like I said, I had to leave that one to you because y'all's OB experience is a lot closer to mine because I haven't had it long. All right, you guys did awesome today. All right, so again, we're gonna do um, our exam review next Friday morning. We have your quiz 5 will be next Friday. And then let's see what else. This is week 8. Don't forget your NCSB and position paper is due this weekend. And other than that, you guys have a great weekend. Safe, be happy, and I will see you guys next week.